Good afternoon and welcome. My name's Janet Major, and I'm the Associate Director for Innovation and Digital Health for the Arizona Telemedicine Program and Southwest Telehealth Resource Center, and I'd like to welcome you on behalf of our entire team. Today's webinar is brought to you by the University of Arizona College of Medicine's Department of Medicine, the Arizona Telemedicine Program, and Southwest Telehealth Resource Center. We would also like to welcome the region that we serve as a Southwest Telehealth Resource Center, acknowledge our fellow HRSA grantees and all other participants. I would also like to begin by reading this beautiful land acknowledgement. We respectfully acknowledge that the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the Tohono O'odham and the Yaqui. The university is committed to diversity and inclusion and strives to build sustainable relationships with sovereign Native nations and Indigenous communities through educational offerings, partnerships, and community services. Since 2011, our Southwest Telehealth Resource Center has been partnering with many different organizations to produce hot topics and have brought to you over 200 different informative webinars. And I want to tell you too, it's the gift that keeps giving. They're all recorded. We have a great archive. So a few tips and notes before we get started. When you join the webinar, your microphone was muted. There will be time at the end for Q&A, and we really do want to interact with you. Please do send your questions and any comments that you have, and fill out the post-webinar survey. This is really important to us. This is how we come up with our future hot topics. And again, look at that webinar archive. Today, we have the honor of hosting Dr. Sairam Parthasarathy. He has been involved in telemedicine and has created a new resource for physicians here in the Arizona that's great for you to know about. It's the Provider Warm Line, and they're offering rural physicians an avenue to ask the most up-to-date COVID guidance from critical care specialists. As it stands, rural physicians who need assistance would call into the helpline with their questions regarding patient cases, and within the 24 hours receive advice, either through text, email, or phone calls from volunteer doctors from Banner. This is a resource that physicians who have been very overwhelmed with trying to keep up with COVID data have asked for. And I can imagine this is exactly what hits the spot. And it makes me think of this morning's conversation with Dr. Richard Carmona and the president of the university, talking about how we have all learned so much about epidemiology, but to sort through all of this information on a daily, weekly basis has to be overwhelming for clinicians, and communication is the key. So thank you so much for being here to share your project, your program, and your way for improving communication and information knowledge for physicians, not only in urban, but particularly in those hard to reach rural areas.
Thank you, Janet. Delighted to be here. I appreciate the opportunity to talk to this group. And yes, I would be able to share my slides here, and we'll be on our way. So we will be talking about provider telehealth, as Janet mentioned. But we will be talking about sort of what is the state of affairs in the field with regards to P2P, is what I'm calling, but I understand there are various abbreviations, meanings to P2P. So I'll stick to provider because it's all been used for things such as peer-to-peer support and things of that nature. So and so provider to provider telehealth, and I will sort of start off by sharing some of the objectives and the questions that we would like to address here. So the focus here will be in the context of this warm line, but also speak to the state of affairs of the provider to provider telehealth and what the future holds, as well as a keyhole view in regards to what is the telemedicine used during the pandemic, and as well as give you some exemplars and reasons for the variations in telemedicine use and as to how we see it, and as well as we'll pepper that with information regarding what are some of the work that we are doing with regards to what is happening in the field, but also what we are doing here in Arizona. And there are things such as the provider-to-provider warm line that I'll be talking about, as well as the provider-to-provider COVID grand rounds that we have been doing, which is pivoted towards long COVID now, as well as we will be talking about a PCORI-funded research study that we are doing that involves rural residents using a telehealth approach. As well as we hope that this will engender questions and future collaborations. Because as you all know, change is the norm, and there's always going to be changes. So I don't need to tell this group that, things regarding why Arizona has strengths in the telemedicine area. And I just wanted to start off by saying that 17% of Americans live in rural areas. And why are we interested in leveraging telemedicine is because not only the COVID pandemic, as well as pandemic preparedness, now that we hope that we are in a better shape, but also with regards to addressing the disparities that's prevalent between the urban and rural population. You know that 50% higher heart disease and 75% higher respiratory disease ails rural individuals, as well as there's 20,000 excess disease or deaths due to cancer. This is essentially undetected cancer that goes on to cause deaths in rural residents every year compared to urban residents. With the COVID pandemic, we saw that rural residents were more likely to be hospitalized or die during the COVID surges. As well as we see that these disparities aren't static. The gap is ever widening. It continues to widen between rural and urban areas, which we hope that telemedicine and telehealth can address. And what are some of the reasons for that? Well, there's access to care, which is what we hope telehealth can address, as well as lower insurance rates in rural residents, as well as there's been closure of rural critical access hospitals across the nation, not peculiar to Arizona, as well as there are, delays not just in physical health related issues, but also for mental health. And so these are sort of a snapshot of the top 5 reasons for death in the US, from cancer to heart disease to unintentional injury to respiratory disease, as well as stroke. And left to right in each one of these cluster column graphs are people living in a central metropolitan area, which is clearly urban, all the way to micropolitan or non-core areas, which are more in the rural territory, and various shades of gray in between them. And you can see that there's progressively greater number of avoidable or excess deaths the more rural that we go, except perhaps for stroke and heart disease. And some of the other things that are ailing rural individuals is, suicide and drug overdose are on the rise following the pandemic. So there is an overlay of the social isolation during the pandemic, and there's an increased amount of deaths that are related to suicides due to depression, as well as drug overdose, and there's a lot of overlap there, as well as difficulty sleeping and stress during the COVID pandemic, which becomes a substrate for developing insomnia, and the insomnia becomes a substrate for depression. And not just COVID disease, but the likelihood of a rural resident getting hospitalized or dying is higher due to non-COVID disease as well. And so essentially, as we spoke about these disparities between urban and rural population that we're hoping telemedicine and telehealth can bridge, there's increased mortality, there's more prevalent chronic disease, and essentially there's reduced life expectancy, less than 3 years on average is the lifespan of individuals in rural America as compared to urban America. And so, there are billions of dollars that are spent on research on genetics and genomics and things of that nature. But what we know is that what really determines overwhelmingly the lifespan of an individual in the US is not their DNA. It is what Alicia Perez-Table, who is the director for the National Institute of Minority Health and Disparities, which is a newly formed institute. What he calls that is ZDNA, which is Z standing for the zip code. So the zip code of residence is a more important outcome predictor for health, well-being, and death in the US than any genetic research that you can do, or which ties into social determinants of health. And so where's the silver lining here is that we have telehealth and technological developments, which gives us hope, and we're hoping that this helps bridge that disparity gap that we have been talking about. And so this is just a graphical display of drug overdose deaths in urban and rural areas. And you can see that there is over time, blue is 2018 and green is 2019 and red is 2020. And you can see there's a sudden step up in the year 2020 of drug overdose deaths and the difference between urban and rural areas. And that's partly because of the pandemic-related social isolation, as well as rural areas having limited infrastructure. And there are, of course, not just opioids, but there are other substance use that are the problem. And I talked about this before, which is sort of the fact that critical access hospitals and rural health clinics are closing across the nation, especially with the critical access hospitals. Even here in the state of Arizona, there have been closures. As well as FQHCs, but you can see sort of this density map of all of these three facilities across the US, and you can see that being in a rural place in the Midwest is not the same as being in a rural place in the Southwest. You can see that there's a sparsity of the amount of availability. So the divide arguably could be greater in certain states because they really don't have those resources that are something that other parts of the country can actually enjoy. And so this is something that is a very notable exception. So just because someone does a rural versus urban study and looks at process and outcomes, the local Medicaid programs in a particular state doesn't mean it's extrapolatable to the state of Arizona. So we have to do our own research for us to inform our decisions and how we approach things. And so I just wanted to say is that along those lines of research, we sit in a very important juncture in time for telemedicine. We talked about how telemedicine is the future and the future and the future. And over the past 2 years, it actually got here with regards to telehealth use. And what you have here is the amount of research grants from HRSA, for example, that have gone towards various aspects of telehealth or telehealth use. And so what are some of the gaps there? Is that there's a huge gap in scientific evidence, which I'll be talking about later, as well as there's the workforce, the provider workforce that we have right now didn't grow up with telehealth and telemedicine. And so they may not be able to embrace this as well as others. There's infrastructural issues, and I showed that in the previous slide with the graphical display. And then there are the specialties. There's a bigger divide in terms of not just when you look at providers, but we look at specialists in rural versus urban areas. The chasm gets wider. But fortunately, we live at a time when there's new policies that are coming down the pike, seeing what happened with the COVID pandemic and seeing how telemedicine and telehealth make a huge impact, and knowing what are some of the barriers for surmounting some of these implementation gaps, as we would like to call it. The current administration is talking about how certain variables are going to be changed with regards to reimbursement changes in terms of whether we're going to go fee for service or value-based care, being able to fund that, as well as giving broader access to broadband internet, as well as addressing some silos that are being created where there's state-based licensing that has limited the ability for us to be able to do telemedicine and telehealth. And I'll be talking a little bit about that in slides as we go along. So I'm a pulmonologist, I also practice critical care and sleep medicine. And so I just wanted to use this as a opportunity for us to actually see that we have 300 million residents in the US, or maybe 330 million. I'm not up to snuff with the exact number here. But when you look at this number, there is only 12,300 or so pulmonologists in the country. And you can see how these pulmonologists fall into these red dots on the left panel there. And this is where all the pulmonologists are. And then what's in shades of blue is the prevalence of COPD, which is the number 3 killer in the United States in terms of mortality is emphysema or COPD. And you see that the density of these states and counties are representative of the burden of disease, and the red dots match up to where these pulmonologists are. So it's almost like you have huge amount of density in Arizona with regards to the amount of COPD people. There's a deep shade of blue, but you have a smattering, or a very small number of pulmonologists there. So right there, you see that there is some maldistribution of specialists to where the disease burden occurs. And similarly, you see with rehabilitation centers, which have been shown that pulmonary rehab can actually make a big difference in outcomes in COPD or emphysema. And you see this again, a sparse amount of such facilities and infrastructural resources in the US Southwest. And so this is what we're talking about. This is what causes that. And so even within the state or within the country, if you look at the urban versus rural COPD disease prevalence, rural populations has about 8.2%, almost twice the number of COPD burden as compared to urban areas. And you find that and there's less, almost a minusculely small number of pulmonologists or experts in rural area. The mass majority being in urban areas or not even being in the US Southwest, they're on the East and West Coast and Midwest and maybe in Florida and Texas, but otherwise you see there's vast areas of the land without adequate representation of these pulmonologists. And so similarly, nationwide, sleep apnea is another common disease. I take care of that. And there's 12% prevalence nationwide. And I would submit to you, although I don't have this data, as to what the rural versus urban divide of disease burden is. And I can tell you there's only about 5,000 sleep specialists in the country. And so the amount of lack of resources is going to be even more significant. And that's why we need telehealth or telemedicine to be able to address that. Now, the portion of this, the vast portion of this talk is on the provider-to-provider telehealth, what I would call as provider-facing telemedicine or telehealth, more telehealth than telemedicine, rather than patient-facing, which is more telemedicine. And these are the questions that I'm hoping that we can cover during the rest of the talk, which is to see what is the uptake of different types of provider-to-provider telehealth in rural areas. We know that we have this capability, we know we have this opportunity, but what has been sort of the uptake that we have seen? And I wanted to share from a history of telemedicine standpoint, I think we in the state of Arizona can be proud, and the Arizona Telemedicine Program shares that history, that the first telemedicine that was done was actually here in the Tohono O'odham Nation, where a NASA-funded program ran the StarFac, which is the space technology applied to rural Papago advanced healthcare, where you can see in this picture here on the left inset, there is a newborn who was ill, and there was care being provided through a primary care physician here, having a teleconsultation with a pediatrician at a different location in an urban area, in being able to provide the care that's needed to help the newborn to be able to come out okay. And so it used satellite technology, and it was a physician to physician consultation. So I would say that this is history of telemedicine, and the Arizona Telemedicine Program is steeped in that deep history going all the way back to 1970s. And the ECHO project, I know we have, super hubs and the hubs here in Arizona and the various institutions. And the ECHO project was, as you know, conceived in the University of New Mexico by Dr. Aurora, which was almost like a case presentation consultation where they present the most difficult cases. What started off in 2013 in a humble way as 13 domestic hubs and an international hub, just skyrocketed into, at least from what I have, the last numbers, about 220 hubs across with more than 135 domestic hubs, with 80 international hubs in over 32 countries. And so this is continuing to expand, which is a provider-to-provider educational approach. And what this is where a case is being presented by a local primary care physician or a provider, and to a panel of experts who are consulting, and then they give advice to this provider to be able to manage that difficult case without the need for a specialist in that particular area. And so that, as you know, many of you are fully familiar with the ECHO program, more familiar than I am, and you can speak to that. Now, what is interesting is that there are only two things that are barriers for implementation in healthcare. It's a very simple takeaway. If there isn't anything else that made sense that I said, these two things are going to be, I think, very important. And we call it the two R's. It is regulation and reimbursement. Those are the two things that are driver as to what's adopted and what's not adopted. Whether there's scientific evidence or not, it seems less material than these two R's being in favor. From a regulatory standpoint, that the health policies of the land and the payer policies allow you to do that, or licensure or whatnot, as well as from a reimbursement standpoint, whether this is actually paying and paying enough and sufficiently paying for the work that's being done. And so I don't want to get into the details here of these codes, but many of you are familiar with these codes. I just wanted to say that telehealth doesn't this provider-to-provider consultation doesn't come under telehealth per CMS. It comes under the Social Security Act. And some of these have more wiggle room than some of the telemedicine laws per CMS. And what we have is these codes that were being developed over many years with, of course, the American Medical Association and other professional societies and CMS. And these are actually coming to fruition with regards to what can be done. And some of these codes are applicable to MDs and DOs, and some are for advanced practitioners and NPs and PAs in addition to MDs and DOs, which are delineated there. So, but the problem is some of these RVU codes are quite small for the amount of time that's going to be spent in terms of how the reimbursement is done. And this can really be a major barrier. We are doing a program here, and I'll be talking about this, and we are not going to be doing any billing or anything like that. This is essentially provider-to-provider education rather than a case-based consultation like the ECHO program. It's going to be quite different, what we call a warm line. It's more like a push forward, which I'll explain in a little bit. And this is not going to be something that is going to be billable or billing, but it's more education to providers in rural area through a provider-to-provider education. But I wanted to say that some of what we do is not only to help, as a land-grant university, to what happens in disparate areas that don't have access to such specialists and such infrastructure, but it is also meant to hopefully be maintained over time, that this is something that will continue past the lifespan of what we're doing with the 2-year funding time horizon. So that's maintenance. So with any implementation effort, we just don't want it to be a single one song wonder, as we in the music industry calls it. But the idea is for that to be sustainability, that whatever we do, if it is good and effective, that it can be continued over a period of time. And without the regulatory and the reimbursement aspects being addressed, it's very difficult to maintain this beyond the life of what we are doing. And what we're doing is through a CDC grant that's funded to the Arizona Center for Rural Health. And it's meant for providers in rural Arizona, although it can be accessed by others as well. And so I don't need to tell this group in the ATP program what happened during the pandemic. And there was essentially a 20-fold increase in March of 2020 in the increase in the amount of telemedicine services. You can see that it spikes down almost like a Wall Street crash there in the holiday week of at the end of the year, and then spikes right back where it left off in the early part of December. And you can see that there's still this high amount of variance, but what is shown on the right panel is that the variance and adoption is different based on specialty. And so in behavioral health, you see there's a 56% uptake at the time that this was looked at a snapshot in time. Whereas in ophthalmology, it's down to 0%. I mean, there's no way they can adopt it because they don't have the infrastructure, the capabilities to peer into someone's retina to be able to do that. And so what I wanted to point out is that pulmonology is at 13%, and which ain't shabby in the scheme of things in terms of rank ordering, but it's still abysmally low compared to where we would like for it to be. And even though this is for telemedicine, one could say that this also applies to telehealth in terms of provider to provider consultation. And so there are some systems which have a process called e-consults where, a primary care provider can actually e-consult a specialist. And there was an 8-fold increase during the COVID pandemic of e-consults through the EMR system, a 6-fold increase in telepsychiatry, and a 3-fold increase in remote patient monitoring. And the e-consults are provider-provider, although telepsychiatry is, would be telemedicine, which is more patient-facing in the emergency department. But you can see that all of these are parallel to each other, and there's a tremendous increase of these, but they're not without some downsides. Well, what is the downside? Well, you can see what happened in the EMR system in terms of portal messages. There's, again, similar skyrocketing of the amount of portal messages that were coming at each individual provider in general. So you can see there's a many-fold increase in the amount of portal messages that patients were sending to their providers. And that can actually be, on the one hand, useful for the patient, be able to get a quick note of reassurance or consultation so that they can actually move on to getting that care. But on the provider side, it can actually be room for burnout. And so whenever we try to do these provider to provider or telemedicine approach, patient-facing approaches, you can see that there can actually be a huge amount of burnout where, because this is not bought into their time of day, and you have providers actually checking their inbox in the EMR system late at night and falling asleep while they're working on it on their laptops. And so that is a nidus, and that is a reason why some people can actually develop burnout. And that's something that we need to be interested in, is the well-being and health of the providers so that we can actually have sustainability of our healthcare delivery system. Then there's the issue of the digital divide. This is actually data from the telemedicine side, but this would also easily apply on the provider to provider side. Is just that, depending upon race or ethnicity shown in the left upper panel, also the socioeconomic stratum, which is shown in blue columns on the left upper panel, or whether someone is in a large metro area or a rural area, which is shown here on the left lower panel. You can see that there is more people in the left lower panel in large metro areas having able to have a digital access as opposed to rural area. But this was actually a reversal, post-pandemic. Actually, pre-pandemic, the amount of rural telehealth access was actually higher than in metro areas because, again, one of those two R's, which is regulatory, that prevented someone who is not in a qualified area from being able to provide telemedicine. And so if there's no telemedicine, then the telehealth provider also suffers. And so, but then after the pandemic and after the parity law, you can see there's a huge jump up in large metro areas. And so similarly, on the right side is essentially a silver lining, is just that this is actually from Ricardo Munoz's work from San Francisco, and he considers telehealth as an inexhaustible source. And so he had a training manual up there on the website, which people can still obtain, that gives the basics of providing certain caregiver advice and support for how depression can be managed. And that can actually be used by someone who's a licensed individual, a social worker, or even a community health worker, while patients are waiting in queue to see their psychiatrist, that they can actually get the care, and it's been shown to be beneficial. And he compares that to an inexhaustible resource because any number of people can use a telemedicine-based approach, as opposed to people, in which case they're in a long line waiting for a clinic queue. And so stroke is an important area. There is an urban-rural divide. This is essentially a platform that can actually wheel in. We have a EICU where the cameras are built into each room here at Banner Healthcare System. Whereas, these mobile units are available in stroke centers, and we are a stroke center of excellence, where essentially a specialist provider in a smaller hospitals that was within one of the 30 hospitals in the system can actually access a stroke center neurologist specialist who specializes in the area of stroke for being able to give advice to the ED physician in the emergency department in order to be able to give the thrombolytic or make the decision to give the alteplase, which would actually make a huge difference in both 30-day recovery as well as mortality due to stroke. And as you know, stroke is one of the top killers in the nation. And this is another way that we can address this health disparity. And so relevant to what Janet was mentioning is that during the acute COVID surges, we had a program called as admin triage. So I carried this pager around myself. And when I would get calls from the surge line. And so sometimes it would be for a transfer. Sometimes someone's asking, saying, hey, I'm calling you from the ED. This patient's too sick to transfer, but any help that you can give for me, I'd greatly appreciate it. And we get this from the Arizona surge line, and we would take the call. And I've actually helped stabilize some of these patients with an intent to transfer, sometimes stabilize them or help them, even though they didn't intend to transfer because they think the patient's too sick to get on a helicopter. But times when it was essentially we were able to stabilize the patient so that the patient can come here safely. So that is a provider-to-provider consultation through telehealth from an emergency medicine department to a critical care specialist here. And that's what we're building upon. And that's where we got this idea to address that specifically to COVID. So this is a different format than the ECHO system, where there's a luxury of time where the case is being presented to a panel of experts and they give them advice. This is happening like boots on the ground. And that's why we call it a warm line, as opposed to a hotline, because the turnaround time is 24 hours for a clinic patient over there. So the question that's in the chat from Angela is regarding if billing for P2P visits, who pays, patient or provider or receiving end? What we're finding is even though these bills are there, these bills really don't pay these CPT codes are there. Nationwide, these CPT codes are rated very low. They don't reimburse sufficiently. So a lot of healthcare systems are actually eating it, essentially. They're funding these programs for them to be able to do. And right now, it is a per-click payment. And I think we're reaching a point where the parity law may go, poof, in which case I don't know how applicable it is to urban areas, but it's certainly applicable to rural areas that are qualified sites. And so the patient will have a copay, and the provider is seeing a small amount of RVU. But what they're finding is that most health systems essentially fund the program by themselves and eat it. Because the amount of labor that they put into the amount of reimbursement is this small. And that's what we're hoping that the current administration can make a change in that. There are other issues as well. There is this issue about the patient getting a bill for something that a provider actually talked to another provider, but the patient really didn't see it. And so then the patient gets a bill not only for going and seeing the provider, but also for a bill of this provider consulting another provider specialist. And so there are some issues related to that. So the thinking right now is not a per click or a fee based payment, but giving parcel payments to local states, and giving to systems to say, okay, we're going to give you a whole lot of money as a package deal. It's almost like like covered lives kind of situation, like an ACO. And so you take that money and then you're supposed to provide the care for X number of clicks to take care of the people in outreach areas that you're serving, which are within your catchment zone, which are rural. Obviously, it won't apply if you're in downtown New York, you're far away from rural land. But of course, in Arizona, in Tucson, where 12 miles out, you're in rural areas, then out of Tucson, in which case it can certainly be applicable. And how is that going to be done? How are they going to check on that? How is that auditable to make sure that there isn't any fraud or issues that still time will tell? But there's convincing that needs to be done as well. So this is front and center, one of the most important areas in ODP, which is Office of Disease Prevention. with the National Institutes of Health, and they're very interested in addressing this because there's a paucity of scientific data informing health policy at this point in time. So it also, as I mentioned, helps with emergency communication from provider to provider, discussion of care and stabilization, as well as transfer management, which I talked about. And then there's, of course, we will be talking a little bit about the P2P warm line and P2P grand rounds as well. So this is the provider-provider grand line. There are 2 infectious disease specialists. There's a data scientist who's helping do that, which is Nirav Merchant. There's an allergy immunologist who can answer questions related to vaccine-related allergies, and 2, pulmonologists are part of the program who can actually address the issues related to COVID, from infectious diseases to allergy immunology to this. The idea is in literally next Monday. I don't have the numbers yet. We are rolling this program out. We'll be able to share what would be the 1-800 line that any provider can call and ask for all of these changing paradigms with, who's, we're ready for a second booster. Who qualifies for the second booster? Can you mix and match the vaccines? What are some of the issues related to the allergies and exemptions? And so these all can be answered by these specialists, and we can get most specialists into that. So the idea here, why we have the Data Science Institute, is that we are able to convert some of those voice messages, or it'll be a person that will be a live line that someone will respond, and we'll get that information. We'll be able to respond, but if it comes at an off hour, we will be able to turn it around to you within 24 hours. That's why we call it a warm line. And we will be able to give you the latest and greatest in terms of what are the changes with the CDC or with societal guideline changes with various treatments or prevention, as well as there's a big focus on long COVID. I mean, as we know, there's 75 million people who have been infected with SARS-CoV-2. They don't have to have COVID disease that put them in the hospital. They can just have a mild infection of SARS-CoV-2 at home, and they can suffer from long COVID symptoms like brain fog, cognitive decline, persistent loss of taste, sleep difficulties, insomnia, breathing difficulties, and persistent cough and things of that nature. And so we would be able to help with the long COVID program and get them involved in both the clinical enterprise, as well as be able to help them be candidates for participating in new clinical trials and new therapeutics that would become available for long COVID. So this is a program that I'd be able to share with you more with regards to the phone number for you to call. But I did want to share with you another engagement that we're doing is, this is essentially a bidirectional exchange of information and education. These are COVID grand rounds. We have had, it started in the month of February. We have 2 speakers who are, immunobiologists and immunologists, and talked about vaccine and the future of what happens to SARS-CoV-2, and now we'll be talking about COVID-19 therapeutics, as well as what it means for long COVID. But Dr. Mosier will be talking on April 19th, and so there's an opportunity for people who want to attend that. You can actually, QR code this, as well as go to seal.arizona.edu and go to the tab on provider education, and you can actually be able to participate in that. And so the uptake has been tremendous. There are companies that are, popping up, which are essentially triaging and transition and trust, as this particular company called Picasso MD is doing. I have no conflicts of interest to declare with this particular company, but essentially what they're able to do is share various ways in which a provider can actually talk to a cardiologist or to an intensivist or to a pulmonologist to talk to them about educational information about a difficult situation that they are facing in their clinic patients, to be able to get the advice. And so the next question that I have here is, what is the effectiveness of provider-to-provider telehealth for rural patients? And we talked about this echo to echo model. We talked about e-consults through the EMR system, and then I talked about the store and forward, which is sort of the warm line kind of stuff that we're doing, which is asynchronous, where we be able to get back to a provider to be able to educate them about the latest and greatest in that particular area. And so what is the evidence? There is in stroke, it's been shown that in rural participants, shown in the first red box on the left lower panel that actually stroke-related outcomes. So the administration of both reperfusion or alteplase or clot busters is greater, and also that translated into a mortality advantage in rural participants. And so, but what's the problem is shown on the right side. You know, it's an abysmally low amount of rural hospitals that have that capability. You know, essentially only 23% of rural hospitals in the US have such, you know, capability, and only 30% of urban hospitals have that capability. And so, you know, so I think Patricia has a question regarding how would you explain the provider-to-provider arrangement to patients? Is there hesitancy from the patient if not directly interacting with the consulting provider? That's a great question. And so there are various prerequisites for billing. And one of the key things is for the patient to give approval and consent and knowledge that this is actually something that's happening. So the provider needs to say, hey, you know what? That's actually a question for a specialist. I don't have that specialist in my area. I am going to be consulting with a specialist and actually getting that information. I'll let you know. And so this happens with various primary care offices. And so it won't be out of the ordinary. It's just that this would be what they need to do. Full disclosure is that there would be a charge associated with that. And so will there be hesitancy on the part of the patient? Yes. And that's why Medicare requires, CMS requires that there be full disclosure and assent on the part of the patient for you to be able to use that particular resource. Another way of looking at it is that even if that is not for that particular patient, there you're doing that only because you want to be able to bill. But if the provider who is in a rural area wants to do that for their own learning, they can do that because it's free of cost to the provider as part of what we are doing. We're not billing anybody, like I said, as part of our program. It's free because we're funded by a grant to Dan Dirksen at the Arizona Center for Rural Health. But 2 years from now, what happens to the program? And if someone else funds this, we won't be able to do this particular program. And our program is primarily directed not for diabetes or cardiovascular disease. It's primarily directed to COVID and long COVID. And so, that's the nature of our provider-to-provider educational program. And it's not a billable service for that regard. So we are not billing anybody. I mean, just doing it as an educational endeavor as a land-grant university. I hope that helps answer the question from Patricia. And so that's what we talk about, that distortion. The distortion is the patient thinks, hey, I saw only one doc, but I get bills for 2 docs. What's up with that? So that's the reason for that. And that can actually have ramifications on the out-of-pocket cost for patients. And of course, there's the administrative cost, burden as well. So when you look at all the studies that's available at this point in time, and there's a little bit dated slide, you see that there's only 23% randomized control trials, which you see on the left lower panel, 23% randomized control trials. And they're in the area of inpatient, outpatient, emergency care, or education and mentoring, which is what we are doing as part of the COVID provider-to-provider program, which is education and mentoring. There's only 23% of all these studies put together that are RCTs or high-level evidence. All of the others have issues or flaws or problems with them. And, and this is a detailed dive into various areas just for the outpatient area, showing how some of them show, with the plus sign, show that there's improved mortality, or when you have a tilde sign, it says that the mortality was mixed, effects of mortality was mixed. And of course, the evidence level is low in this area. And this is for infectious diseases through the ECHO program. It has the most robust indicators that it can actually help with the antibiotics prescribing or management of hepatitis C, or in the case of diabetes and mental health, it's all positive as well. So these are the specialty areas where ECHO has most bang for buck, and it's worth the expenditures and the effort. And so the summary of evidence, and I know this is a busy slide, and I just wanted to say is that there is not enough data. A lot of this data shows how there's more benefits, but no one talks about unintended consequences, patient complaints, or harms or unexpected negative outcomes. There's a paucity of reporting on that. But we do believe that overall it's good, but the evidence needs to be accumulated. And here I just wanted to say is that you want to take telehealth approach and see if it's comparable to standard of care and do probably a non-inferiority study of RCT, telehealth versus in-person, and see if there is a benefit. But then what condition, what patient, what type of telehealth, what are the outcomes we should look at? Should we do a quantitative study or qualitative study? All of that is, less clear. This is a study that we did for insomnia. And so I'll just share, as a shameless plug here, we had an office-based cognitive behavioral therapy for insomnia, or a telemedicine-based approach. And it was a non-inferiority study. And we looked at what we call an insomnia severity index, which is our, measuring tool for how severe the insomnia is. And when we did these forest plots on the right part, we can see that that telemedicine-based, CBTI was actually not inferior. In other words, was comparable to in-person CBTI. And we actually did this in the first year of the pandemic. And so we should show that that was comparability. It's built into the first year of the pandemic, rather. And but then, at least in some of the models, we found that the telemedicine was superior in approach. And actually, when we look at patient satisfaction, which is an outcome that I'm not shown in this first plot on the right, patients actually preferred the telemedicine option for cognitive behavioral therapy, which is a mental health-based approach, or a cognitive, CBT approach. And they actually preferred telemedicine platform as opposed to a in-person. So it just talks about the convenience for how this approach happens. And pivoting out of that, we're doing a study where we're involving both patients and providers in rural areas. And so for that, I have a phone number, which is out here. It's 520-626-0918. And so insomnia afflicts rural populations more so than urban populations, believe it or not. And we think that it's also tied in with the pain pandemic that was going on prior to that. And so this is comparing cognitive behavioral therapy administered through a app or telemedicine-based approach. But here, what we're doing is we're also doing in education and CME for primary care providers who are in rural Arizona. And so if this is something that would be of interest for people, feel free to call this number, and we can get your practice plugged in. And I'll end with the last 4 slides here, which is what strategies are effective and what are the barriers and facilitators. And, the barriers are, as I said, the 2 R's: reimbursability and regulatory aspects. These are the 2 barriers. And people aren't having a service that's covered versus, was something that is covered, that can make a big difference, as well as, a provider may be ineligible, or the amount of fees that they get for the service can be low. So all of those are barriers. Even though we have CPT codes right now to do this, the fees are low, and so the adoption is going to suffer. There's also disparities by race and ethnicity and region. It's just not by just rural versus urban. And because there is a digital divide between various race ethnicities in the US, that can also affect, be a barrier. But the 2 most frequently cited barriers are, level of resources that are available, in form of broadband or internet access, and language barriers, as well as access to digital information and knowledge about how to incorporate the telemedicine or telehealth program into workflow. So we're making it easy. We just have a phone number where people can call. As I shared one phone number, I'll share the other one as soon as it becomes available next week. I apologize that it's not ready to roll right now, or this week rather. And so those are all the 2 main barriers. And in a rural area, there's a familiarity issue that, someone in an urban, a specialist in an urban area, may not be familiar with the rural practice and not know what are the resources and whatnot that's available on the local site, or technology support is not adequate in either the urban or the rural area. And so a question from Christopher is about e-consults. So the e-consults are not being done in Banner, although there are some specialties that were doing it in the past between smaller hospital and larger hospitals. But what is happening in the form of e-consults is tele-EICU, which is happening in a big way. And I have a slide on that, and I can share that with you. But the VA is doing a lot of e-consults. In fact, you cannot get a regular consultation without having passed through the e-consult litmus test. So the VA, the Southern Arizona VA healthcare system, and the CBOX in a hub and spoke, along with the Phoenix VA and the CBOX, are doing a hub and spoke through e-consults from the CBOX to the main mothership, be it in Phoenix or Tucson, and that becomes a gatekeeper. And so if they pass the e-consult, if it's not taken care of by the e-consult, then they come in for an actual consultation at the urban area. And so this is a graphical display as to what are some of the top 5 issues or barriers, which I already talked about. And so this is relevant to the question that just came from Christopher, is that the way these e-consults are happening is happening in real time in the ICUs in the Banner healthcare system. So there are 30 hospitals now across 5 neighboring states. And there's an algorithm that's running in the background. It's called a Safe Alert. It's checking the vital signs, it's checking the labs, it's checking other information that's available in terms of the demographics and culture results and whatnot. And any one of them can actually trigger an algorithm that pops up as a window. And when that window pops up, someone sitting at a control and command station in the EICU gets the safe alert. They get a list of patients who need a safe alert. And they can actually go to that safe alert and actually pull out that particular patient, actually call in along with video audio ability to talk to the ICU nurse or the doctor who's on call in that particular ICU room and actually have a conversation, actually be able to look at the ventilator, zoom in on an eyelash on the patient's eyelids and zoom out and see what's happening with the ventilator, what's happening with the patient, make the call to intubate the patient or not. So the EICU, not in the urban ICUs that's here in Tucson or in Phoenix or greater Phoenix, but in the smaller hospitals that are in more rural areas that are part of the Banner healthcare system, this is an immediate stat e-consult that happens that nobody needs to even generate. This is a sort of machine learned algorithm that's actually running in the background, and it pops up an alert and immediately pops up on a dashboard in 2 stations in Phoenix or in Tucson, where some ICU doc is sitting there and manning that console, and they're going to zoom in into that room, and all of a sudden, if you're in the room, you'll almost hear this voice booming. You don't see the person, but then you can actually hear this person talking to you saying, hey, what's going on? Looks like your patient is deteriorating. How can I help? And so that is sort of an advanced form of e-consult where it's not even requested, but it's triggered automatically. And there's no billing happening for that. That's essentially borne by the system, because it knows that this resulted in better outcomes in the ICU patients. And so this is actually ongoing work that's happening right now, and it's been happening for a while. So the weaknesses in this area is that, like I said, only 25% or 23% of the studies are randomized controlled trials. So we need to do more research in this area and be able to do it. As I said, the RCT is the top bar, or the litmus test for what works and what doesn't work. And essentially, a lot of the research becomes then difficult for us to attribute as to what is beneficial and what's not. So I'll just stop there, and I think I ran through a whole bunch of slides, but I wanted to make sure there's sufficient time for questions. But I just wanted to thank these 4 sources of funding, especially the CDC grant through ADHS, to Dan Dirksen here at the University of Arizona, that allowed us to engender the provider-to-provider grand runs as well as the WOM line. Take it away, Janet.
Thank you so much, Dr. Parthasarathy. This is amazing information for our rural clinicians and urban clinicians too. You know, it's interesting because telemedicine is no longer necessarily about urban and rural in many situations. And I think we're all fortunate to have the access to the resources that you provide. I'd like to see if anybody else has any other questions that they would like to ask of you. I shared the URL in chat. The handout will be available with the archive if you visit our archives. So you would then have any of the contact information or URLs that were shared. I also wanted to mention, you know, that there's a really big super hub of ECHO in Nevada at the University of Nevada at Reno, and I'm a big fan. They do a lot of really amazing work and have a very busy schedule. And on Tuesday, May 31st, they're offering CME for a 1-hour presentation on implicit bias in medicine, a panel that sounds really interesting. And they also, every month, if you're interested in investigating, of course, the UNM Echo website is the big major hub, but UNR is a great hub too, and they have great resources, and every month they do a session on how to do, what is echo, how to do an echo, if you would like more information about that. Any other questions? This was really great. Thank you so much. It was a pleasure to meet you.
Likewise, thanks for having me. And as I said, if people are providers in rural Arizona want to be part of our endeavor to educate them about insomnia, as you know, especially during these pandemic social isolation times and loneliness. You can call this number at 626-0918 with the 520 area code, and when available, we'll send participants information for the long COVID warm line, which I believe will be available Monday of next week. So we'll get it to you.
Thank you so much. And I'd like to remind all of our participants to please do fill out the survey. We really value your opinion. And as you close your Zoom meeting, you should automatically go there, but I also put the link in chat. And thanks again. I really appreciate you being here.
Yeah, and I also put my email address. I know there's some who are wondering whether they could actually, get some help regarding tele approaches with their area of specialization. So feel free to email me at that address. I forgot to put it on the slides. Oh, it's down there on that particular slide. It's down on the bottom. I put it also in the chat, so people can just email me if this is something either in the long COVID area, or if you are in the insomnia area, or if you just want to use some of these principles for you to develop a program in your specialty. Happy to help and advise. We've been doing research in this for many years, including the Tele-ICU in the Banner system, which we published, which I shared the publication. So we've learned, and you want to learn from our mistakes and not relearn your mistakes. Yeah.
And that's how you keep your closets empty of a lot of stuff you don't need. I would like to also respond, mentoring help in teledentistry. I'll follow up with you on that offline. We have had a couple of teledentistry presentations, and maybe they would be a good resource for you. I just don't know of anyone off the top of my head. So any other questions? Going once, going twice. Well, thanks. Great way to start our week.
Thank you. Take care. Bye-bye.
Bye now.